Welcome to MedEd's production of the Medical Surgical Exam Review. This module is to help prepare you for your certification exam, and we're going to cover endocrine disorders. My name is Beth Grace, and I'm a family nurse practitioner who's been practicing in nursing for almost 30 years. Moving on into our module now. Again, Medical Surgical Nursing Exam Review, endocrine disorders. You know you're going to get questions about diabetes, and we'll get to that. But first, let's look at thyroid disorders. Thyroid gland, it's responsible for producing tridothyronine T3 and thyroxine T4. The hypothalamus produces thyroid releasing hormone, or TRH, and this stimulates the pituitary gland to produce thyroid stimulating hormone. So this process is sometimes called or referred to as the hypothalamic pituitary thyroid axis. So anytime there is any malfunction in this process, it's going to lead to either hyper or hypothyroidism. And we do know that the role of the thyroid hormones is to convert oxygen and calories to energy. So first, let's look at hyperthyroidism. Hyperthyroidism means we have an excessive release of thyroid hormones. Most common type is called Graves' disease, and it is 5 times greater incidence in females than in males, and it's also considered an autoimmune disease. That's hyperthyroidism. And just by looking at that prefix hyper, you know that it's going to increase. It's going to cause things to move faster, work harder. So knowing that, we have an increased metabolic rate. The heart rate's faster, tachycardia. We have increased GI function. Diarrhea is not uncommon, so you see weight loss. These patients do not tolerate heat at all. And as you notice in my picture there, the fellow with the eyes that are bulging, this is known as exophthalmos, and is a characteristic of some of our patients who have hyperthyroidism. So we know that we're going to see an effect on metabolism of fats, carbs, and proteins because of this hypermetabolic state. Now we want to watch for crisis. Hyperthyroidism is well managed with medications or in some cases surgery. But there are conditions that can lead to problems. So while we're taking care of patients in the hospital who have hyperthyroidism, we want to assess for thyroid crisis or thyroid storm. Who's at risk? Well, the patient is at risk when they become stressed by infection or they've had thyroid surgery. So if they're in for pneumonia, they can actually go into thyroid crisis or thyroid storm. So this is something we're going to assess for each time we do that initial assessment or shift assessment of our patient. Temperature, when they do develop thyroid storm, skyrockets. 102, 103, the heart rate increases, their blood pressure goes up, they may complain of severe abdominal pain, nausea, vomiting, and or diarrhea. They become agitated, they can become confused, they get the shakes. That indicates thyroid crisis. So now, are we going to manage this patient with this hyperthyroidism or potentially going into thyroid storm? Well, it's all about inhibiting the synthesis of thyroid hormones. High-calorie diet may be ordered because, again, they're burning up these calories because of that hypermetabolic state. We'll take measures to lower the temperature, administer steroids to manage that inflammatory process and the immune process because it is an autoimmune disorder. Treat arrhythmias, maybe with beta blockers, for instance. Replace electrolytes as needed. Treat adrenergic response. Again, that is that tachycardia, so we may again give them a beta blocker here. A potential treatment for this patient is radioactive iodine, and then there's always the option of surgery. There's also medications that can be given for this particular disease process, that hyperthyroidism. One is PTU and Tapazole. Tapazole is the one that I see most often, It blocks the synthesis of thyroid hormone and it decreases symptoms over time. Another potential treatment is sodium iodine and potassium iodine. It's not as popular as it was in years past, but these treatments can also inhibit the synthesis and release of thyroid hormones. So a few little pearls when it comes to taking care of that patient with hyperthyroidism. One, remember that it's all about assessing them, knowing where they're at. Is their disease under control? You looked at their history. They've got hyperthyroidism. Are they showing any symptoms of going into thyroid crisis or thyroid storm? If so, what type of interventions have we put into play? Have they been implemented? And if so, what was the patient's response to them? Okay, so we're always thinking of this process when we're taking care of our patients. Now, pearls again. Older adults should be monitored for signs and symptoms of heart failure, because remember, those tachyarrhythmias can potentiate heart failure, diastolic heart failure in particular. Now, patients undergoing thyroid surgery, again, they need to be monitored for those signs and symptoms of damage to another gland, the parathyroid gland. That can potentiate hypocalcemia and tetany. So again, know the complications that go along with this disease when we are putting different options in for treatment. Okay, now we've looked at hyperthyroidism. Let's look at the other side of the spectrum, hypothyroidism. Now this can happen from damage or loss of thyroid tissue, deficiency of T4 itself, inability of the thyroid to produce T4, or in that, hypothalamus pituitary axis there, we could have a decrease in that TSH from the pituitary. Hypothalamus derangement, as I mentioned, if there is a problem in any part of that progression of stimulating the thyroid, then we're going to have issues. Surgery, radioactive iodine, treatment of hyperthyroidism can actually potentiate or lead to hypothyroidism. Makes sense. If you had a patient who had thyroid cancer, you removed the thyroid, now that patient has hypothyroidism and will be treated as such. So now what do you see in that patient with hypothyroidism? When you're assessing a patient, common findings: fatigue, weakness, this patient can't stand the cold, constipation, because now we have a hypometabolic state, right? Yeah, things slow down. Unexplained weight gain, they have those brittle nails, thinning hair, dry skin, the memory's off, a decrease in their mental acuity, and then a slow heart rate. It's actually interesting. As we get older, a lot of times when you complain of memory loss or a decrease in attention span, one of the first things that they check you for is your thyroid. Yeah, to look and see where your TSH is at. If your TSH is very high, it means that you have hypothyroidism, because your thyroid is producing, but it's not using. So very high levels of TSH indicate hypothyroidism, whereas very low levels indicate hyperthyroidism. Now with this particular condition, with hypothyroidism, one of the most common life-threatening incidents that can happen is called a myxedema coma. The patient gets very sleepy, cannot stand the cold at all. Their temperature is subnormal. It may be down there at 96.0 or 35.0. Their blood pressure drops and their breathing slows down. I took care of a a young lady in her 30s in ICU some years ago who came in with myxedema coma. And the source of this condition was she hadn't taken her thyroid pills, her thyroid replacement hormones, in 4 or 5 days, and she didn't have a thyroid gland. Hers had been removed because of cancer. And not only that, she was also a brittle diabetic. Once they figured out what was wrong with her and corrected the problem, put her on steroids, got her back on her medication, she did fine. Then it was all about educating her on her condition. So managing that patient with hypothyroidism, as I mentioned, you've got to give them thyroid hormone replacements. Steroids plays a role in caring for this patient as well. Again, this is an autoimmune disorder. Steroids work on an inflammatory process. Patient education on dietary restrictions of foods that might interfere with the utilization of those thyroid hormones, such as spinach, peaches, carrots, and cabbage. Know that this exam is going to focus on the things that they do after they leave the hospital. They're going to look at interactions between medications and foods. That comes up quite a bit, so keep that in mind. So educate your patient also on the best time to take their medication when it comes to those thyroid replacement hormones, right? The recommendation is to take it on an empty stomach 30 to 60 minutes before a meal. Now in the hospital, we're very regimented, and it's given usually every morning 30 minutes before they eat. But depending on this patient and what kind of lifestyle they have, that may not be the optimal time for them to take it. So as long as they take it on an empty stomach 30 to 60 minutes before a meal, they should be fine. We also need to think about dietary restriction of iodized salt and any preparation with salt. It should be avoided because thyroid medications can actually enhance the effects of iodine and could potentially lead to iodine toxicity. Does that happen frequently? No, because I think in this population of patients, just like in the cardiac patients, that they're taught about sodium restriction in their diet. Excuse me. Okay, a few other pearls when it comes to thyroid medications. Remember when teaching patients that thyroid medications can enhance the effects of anticoagulants such as Coumadin, of digitalis, and also it can alter the patient's response to insulin. So keep that in mind when you're looking at the history of your patients. It could come up in a question on the exam. All right, do we need to worry about a patient's Coumadin level who is also on levothyroxine, for instance? You know, do we need to monitor their insulin levels any closer because we're starting them on levothyroxine, for instance? Okay? Patients with a history of heart disease also should be monitored for adverse effects from thyroid replacement therapy, because this is going to put them more into that hyperthyroid state, right? Or normal state, we're hoping. Now this therapy, though, could increase that oxygen demand brought on by an increase in metabolism. So we keep that in mind when we're teaching our patients as well. We monitor them for these problems, but we're also going to teach them to look for this when they're at home. So monitor them for chest pain or angina, because it can provoke that, dysrhythmias, and pulmonary complications. All right? Now another piece in this endocrine world, and we're not covering everything because, as you'll notice, I don't have adrenal insufficiency in here. So you might want to make note that I'm not going to cover adrenal insufficiency, so you want to cover it on your own, okay? With Cushing syndrome, we now have a hyperfunction of the adrenal cortex that's caused by too much cortisol. You know, one of those fight or flight hormones. Now this could be caused by an abnormal cortisol production or excessive corticotropin stimulation. That's usually due to some type of pituitary issues, or this patient has been on long-term steroid use, glucocorticoids in particular. Think about your patients who, your pulmonary patients, for instance, on long-term glucocorticoids. Think about your patients with Crohn's disease who take steroids. Now, what do you see in this patient? What do you expect to find during that assessment? And not only that, once you've made your assessment and it correlates with the diagnosis, and you're going to anticipate diagnostics that they may do on this patient, you know, interventions, those types of things. So we're seeing that muscle weakness and atrophy in this patient. They're worn out. Fat deposits on the trunk, abdomen, over the back. They have that buffalo hump or that moon face. This patient too, we would look at their skin. They get this hyperpigmentation, sometimes striae across the abdomen, bruising, and facial flushing. Now there's a good example of that buffalo hump, okay, and another is that striae. Now does everyone have these that has Cushing syndrome? No, they may have one or the other. They may just have the facial flushing. Everybody's a little bit different in their response to this disease process. But it's all about educating your patient on the disease process and teaching them how they can function with this disease. Something else that might occur is gynecomastia in men and irregular menstruation in women. Other signs that we may see or encounter with Cushing syndrome: arrhythmias, edema, mood fluctuations, GI disturbances, headaches, hirsutism, or that fine downy hair on the face and upper lip. Their potential risk for infection, and weight changes are not uncommon with Cushing syndrome, okay? A little plus on the weight changes, you might say. So now we know about this patient. We've assessed this patient, we're taking care of them, we're monitoring the patient, and we are listening to their concerns. And one of their biggest concerns has to do with body image. Can you imagine if you developed that facial hair and you're a woman, or the buffalo hump, or you're so weak that you can't get around without using some type of assistive device? All of these things we're going to have to take into consideration when we are communicating with our patient about their disease process and what they're going to need to do to get the best function when they leave our care. Okay? So we're going to provide measures to help protect our patients from injury related to the abnormal fat deposition and loss of bone matrix. We're going to instruct them in the use of assistive devices, or we're going to collaborate with another discipline such as physical therapy to do that for us. We want to minimize venous sticks because these patients bruise very easily. If they do have an adrenalectomy, we're going to monitor them for hypoglycemia and now signs of adrenal crisis. So moving along, okay, another problem that we may see, we were just talking about adrenal crisis and hypoglycemia. So let's take a look at hypoglycemia itself. You know, it's a very basic problem, one that we see quite frequently, and it's actually one that we perpetuate in the hospital setting at times. It's an abnormally low blood glucose, can be an acute complication of several diabetic treatments. It can be because in the hospital we have a tendency to keep really tight glycemic controls because we know that hyperglycemia can actually increase the opportunity for infection. So we try to keep them within very, very tight controls, and that can actually lead to hypoglycemia. Medications that we give can lead to hypoglycemia or can mask it. Beta blockers, for instance. Antibiotics have been known to perpetuate hypoglycemia, Bactrim, etc. And pentamidine can also perpetuate hypoglycemia. And we just mentioned in the previous slide adrenal insufficiency. This can cause hypoglycemia because of the decrease in cortisol and epinephrine release. Yeah. Treating a patient with diabetes who's in diabetic ketoacidosis, that can potentiate hypoglycemia because initially they're going to be on an insulin drip, which can drop that blood sugar very quickly. All of these things we're keeping in mind when we're taking care of our patient who is admitted for any type of endocrine disorder, hypoglycemia, diabetes, anything of that nature. So we see acute hypoglycemia means the blood glucose is less than 60 milligrams per deciliter. So we have a decrease in glucose production and sometimes or an increase in glucose utilization. Some of the other etiologies for hypoglycemia. Insulin receptors are oversensitized. A patient is a diabetic and they exercise too much. Can lead to hypoglycemia. That's why that's another teaching point when you send a patient home that has diabetes and possibly ended up in the hospital because of an acute hypoglycemic event that was caused by too much exercise. Drugs. There are hundreds of new medications for glycemic control. Non-sulfonylureas, hypoglycemic, glipizide, glucotrol, all of these can lead to hypoglycemia. Decreased dietary intake can lead to hypoglycemia as well. Think about those patients that we take care of and we make them NPO. Or that patient that's had surgery and has no appetite afterwards. Decreased dietary intake, potential for hypoglycemia. Other etiologies, not enough glucose production. Let's think about the liver here. A decreased gluconeogenesis in the liver. The body's unable to produce glucose due to liver or kidney disease, i.e. alcoholic ketoacidosis, for instance. Or a decreased glycogenolysis, which means that the body is not able to use the glycogen stores to raise the blood glucose. Yeah, this could lead to hypoglycemia. So a little pathophysiology. When that blood glucose decreases, substances that increase blood glucose are actually secreted. This is our body's mechanism of taking care of itself once again. So it releases epinephrine, glucagon, glucocorticoids, or cortisol, and growth hormone. That's what we do on a daily basis in order to maintain our hemodynamic state, a normal hemodynamic state. But if these methods fail to raise blood glucose to a normal level, that's when we see symptoms appear. That's when we see symptoms appear. That's when we see our patients get shaky, diaphoretic, confused, because our normal mechanisms can't fix them. So now we have to intervene. We've assessed, done a little diagnostic test, maybe with an Acute check. Their blood sugar is very, very low. So now it's time to implement an intervention and treat that problem, that hypoglycemia. So if they're awake and alert, probably going to give them a cup of skim milk, a non-diet soda, and recheck in 20 minutes. Everyone has got a different policy that guides therapy or treatment modalities for a patient who is hypoglycemic. Now, if they're hard to arouse, they're symptomatic, then we're going to go for the quick fix. An AMPA D50 IV over 3 to 5 minutes. Now, if they don't have any IV access, let's say that this patient is in a long-term care facility where they don't normally have IVs, then they can actually give them glucagon. All right, they can give them glucagon. Then we've got to find out what caused this event and then treat the underlying cause. So it goes back to history and what were they doing. So the biggest sugar issue, of course, in our nation today and probably worldwide is going to be diabetes. Diabetes. And you know you're going to have questions on diabetes. You're going to have questions on teaching the diabetic. You're going to have questions on treatments for the diabetic. You're going to have questions on diet for the diabetic. You know, so keep those all in mind as we go through this this next piece here. Because we're going to look at new onset diabetes, we're going to look at new onset diabetic ketoacidosis and hyperglycemic hyperosmolar syndrome, and we're going to look at patients that adhere to their diabetes regimens and those that do not, and non-compliance. That's always an issue when it comes to taking care of a patient with diabetes. So diabetes itself, just a quick look at the patho of this. Cells are unable to take in glucose. We know that type 1 has little to no insulin production. Type 2 Type 2 does produce insulin, and it can be low, normal, or high. We know that the insulin itself is produced by beta cells on the islets of Langerhans in the pancreas. Sounds kind of like a tropical island, doesn't it? Yeah, interesting. Well, it is required for cells to take in glucose, that insulin. Got to have it. If you don't have it, then that glucose can't move into the cell. So let's talk a little bit about complications of diabetes, such as diabetic ketoacidosis. This is usually related to type 1 diabetes. Many times this is what ends up bringing them to the hospital, and they haven't even been diagnosed. Can you have or experience DKA in type 2 diabetes? Yes. Is it common? Not really, but it can happen. Other problems, insulin omission could lead to diabetic ketoacidosis. They haven't been taking their insulin. Maybe it's because of compliance or non-adherence, or they don't have the money to buy it. We're not real sure, but that will lead to diabetic ketoacidosis. And that's part of the teaching process too. You know, if you don't take your insulin, you can end up back in the hospital. And sometimes in the clinic, I see that when I'm teaching patients. And they're like, oh, well, I've been in the hospital with DKA before. Like it's no big deal. Well, end up in the hospital enough times with DKA and you're going to kill your kidneys. Okay? Infection can perpetuate diabetic ketoacidosis. And then there's other etiologies as well that can raise the serum glucose, such as pancreatitis, trauma, because it's the body's response to trauma, okay, is to increase that inflammatory response and turn on that immune system, and that immune system is going to kick in the insulin, okay? It's going to kick in that piece. Stroke can also lead to diabetic ketoacidosis. Glucose is typically 250 to 800 milligrams per deciliter. Many of you know and have seen the symptoms, the manifestations that patients present with when they have, excuse me, diabetic ketoacidosis. Lethargy, postural hypotension, excuse me, Kussmaul's respirations, which are those slow, deep respirations, or I'm sorry, fast, deep respirations, because they're trying to blow off that CO2. Abdominal pain brings them in. This can mimic an acute abdomen, for instance, and again, sometimes that's why they come to the hospital. They don't come to the hospital because they know they're in DKA. They just have this horrid abdominal pain and they've got nausea and vomiting. And sometimes this is when we end up diagnosing them with type 1 diabetes. So again, you know that you've assessed them, you're seeing the signs and symptoms and presentation of diabetic ketoacidosis, you're anticipating interventions due to the orders that are placed by your physician, you're going to implement those and then reevaluate and determine outcomes. So glucose greater than 250 is what we're going to see to diagnose ketonuria or ketonemia, a pH of less than 7.30 on a blood gas, or bicarb of less than 15 on a chem panel. And you're also going to see an increase in that anion gap. So treatment, first thing you do for these patients, of course, is you give them fluid, because think about the symptoms. One of the symptoms is they're peeing all the time. They may be drinking and thirsting and eating, but they're also peeing constantly, so they're losing water. So we want to correct that first. We want to correct the hypovolemia. They may have a free water deficit of 5 to 11 liters. So we're going to start them on normal saline, at least 2 liters over an hour for the first hour, and then we're going to adjust it accordingly to urine output or to your facility's hyperglycemia or DKA protocol. Okay? Once a blood glucose is brought down to 250 or less, they're probably going to change that IV fluid up and give them back a little sugar and half normal saline. At that point, too, we're going to think about electrolytes, because with this fluid loss, you're also going to lose potassium, you're going to lose sodium, you're going to lose phosphorus, you know, so we're going to monitor these electrolytes, and most protocols for DKA also have an electrolyte replacement protocol. Now they get sodium with the normal saline you know, when they get that initially. So that's usually not an issue. But the issues are going to be the potassium and the phosphorus levels. All right, they may initially look elevated. That's a that's a misnomer. It's falsely elevated. It is, as they are being hydrated, it is going to come down. Treatment, again, you're going to go by your facility's policy and procedure for hyperglycemic states, and initially it's going to be an insulin drip, and then we're going to start changing them up as they stabilize them and we get them out of that acidotic state. We're going to schedule long-acting and prandial insulins, and at this point too, you know, we've already started that teaching process. That starts on admission. When they come through the door and we're recognizing what's going on with them, the teaching begins. And many times we don't even realize we're teaching, but that's what we're doing. Okay? So now there's another state that we look at too, and this is in type 2 diabetes, and that's that hyperosmolar hyperglycemic syndrome. And with this one, the mortality is probably higher because the glucose is much higher, and it's because they produce a little insulin, so they don't have the exact same signs and symptoms as a patient with diabetic ketoacidosis. So here we have a relative lack of insulin. They're not ketotic, or at least not significantly so. They have type 2 diabetes. They're typically elderly, and a lot of times they're undiagnosed. And what set this off was another infection. They have an upper respiratory infection, a urinary tract infection, and this causes an increase in their glucose production. Okay, and it goes unchecked. It goes unchecked. And they develop severe dehydration. Their glucose is going to be greater than 600, but usually by the time they end up in the hospital with HHS or HHNK is what we used to call it, their glucose is 16 to 1800. It is dramatically elevated. They're lethargic, they're hard to arouse, they're tired, I mean all the way to comatose. They have polydipsia, polyuria, so they're thirsty, they're peeing, they're eating, polyphagia all the time. They've got this dry, flushed skin, dry mucous membranes. Look at they're just dehydrated. So you see that tachycardia and hypotension, which goes along with that. But they're not acidotic, so you don't have those Kussmaul's respirations. Instead, you have these little shallow, rapid respirations instead of the deep, rapid respirations. Again, it's not ketotic. The sodium and potassium loss depends on the amount of dehydration. You may see a mild metabolic acidosis, and that's usually due to lactate or renal dysfunction. Now, what you're also going to see on diagnostics is a serum osmolality that's greater than 350. And that's because the higher the osmolality, the drier the patient. So serum osmolality greater than 350, high and dry. You know, a normal serum osmolality is usually 280 to 295, for instance, 280 to 295. So this patient's dry as a bone. Glucose, again, usually greater than 600, often greater than 1,000. And like I said, I've seen it 1,600, 1,800. So again, the treatment is similar here as it is to DKA because this patient is so dehydrated. We're going to correct the hypovolemia, normal saline first. Most patients, they could need anywhere from 8 to 12 liters in the first 24 hours. Again, once the glucose is dropped below 250, the fluid is changed up to give them some sugar back. So it's going to go to D5.5 normal saline, and they're going to add potassium to IV fluids as indicated by monitoring those electrolytes. That's the other diagnostic piece there. So your interventions are going to include hydrating that patient and monitoring their blood sugar and their electrolytes. Again, follow the facility protocol as far as that insulin drip goes. A lot of teaching is going to be needed for this patient. So considerations when you're taking care of that patient in an acute hyperglycemic state: cardiac and vital signs monitoring. Neurochecks, it can affect their mentation. If that blood sugar, for instance, goes too high, they can go into a coma. They can have seizure activity. frequent blood glucose checks per protocol. Monitor those I&Os. Are you hydrating? Are they putting out as much as they're taking in? Daily weights. Assess respiratory status. Monitor their electrolytes and begin the education. That education can't be begun until you evaluate their readiness to learn. And I know I'm redundant on that, but if they're not ready to learn, all the teaching in the world is not going to help them. During that evaluation of readiness to learn, if they're ready to learn, then you have to identify what level you can teach them at. You know, the level of cognitive comprehension. I can't teach a second grader the same as I would teach a college student. Communication barriers. This is a point you need to think about that too before you start your education. Communication barriers. Do they speak English? Do you need a translator? You know? Cultural issues. Got to think about that too before you start to educate this patient. That cultural issue may play a role as far as nutrition goes. We need to bring in a dietitian because we are going to emphasize the importance of adhering to caloric intake based on the American Diabetic Association. And the meal plans are going to need to be designed to meet the individual needs of the patient. And again, that is addressing the diabetes, but at the same time taking into account cultural aspects. Don't forget that. That's going to come up several times in this test as well. Provide written materials and videos while they're in the hospital. And you know, it's interesting, if your patient does have access to a computer, maybe not at home but at the library, they can also go in and access most hospitals' libraries or discharge videos from a portal outside of the hospital, you know, so that they can look at it again and again and again until they understand. Because from what I said about health literacy, we really need to make sure that they understand what's going on with their disease process and how they can optimize function before they leave the hospital. We need to connect them with resources in the community. We need to collaborate with our diabetic educators, with our dietitians, with all of those resources when they leave the hospital. So medications, we know that these patients with DKA, they're going to go home on insulin and they need to be taught about insulin. And you'll probably get a question about insulin. And it's interesting right now, I have been to probably 5 or 6 presentations on new diabetic medications. I mean, it's crazy. They're just cranking them out, you know. I mean, there's so many different ways to address the blood sugar, you know, via the gut, via the pancreas, via the liver, via the intestines. Now you can actually get them to pee it out. It's crazy, okay? But in the hospital, they're going to be given the basics. And most, because of their economics, will probably be put on medications that we know that they can afford, okay? So insulin, think of rapid acting. We're going to go with insulin Lispro or Humalog, excuse me, insulin Aspart, Novolog, insulin glulicine or Apidra. Don't see that much, but occasionally. Onset 15 to 30 minutes, peaks in 1 to 1.5 hours, last 3 to 4 hours. Then we have our short acting, okay, insulins, and that's your regular Humulin R, for instance, and your Novulin R. The onset of these, 30 minutes to an hour, peaks in 2 to 4 hours, last 5 to 7 hours. Now these insulins are usually the ones that we use for prandial coverage for those sugar surges during meals. Then we have our intermediate acting, which is our NPH. Our Humulin N, onsets 2 hours, peaks in 6 to 8 hours, lasts 12 to 16 hours. And we don't see regular NPH used separately like we did in the past. Nowadays you might see them put on a mixture of what we call 70-30 because it is more cost effective, and it will give them both that short acting and intermediate acting response. Then we have the best method is to address that type 1 diabetes is by putting them on a long-acting insulin, like insulin Detamir, which is Levemir. Its onsets in 2 hours. It peaks in 16 to 20 hours, can last 24 plus hours. Then we have Lantus. Lantus has been around for quite some time. It's another long-acting or basal insulin. Onset is 3 to 4 hours. There is no peak, and it lasts 10 to 24 hours. So there's a lot of education that is going to take place when you are discharging a patient who is diagnosed with diabetes. And it may be a new diabetic, or it may be an old diabetic who just needs new teaching because they don't understand how to use their insulin appropriately. Or maybe we change their insulin up. Then we also have oral and injectable hypoglycemic agents, and these are all listed in the handout. There's just way too many to try and go over in one sitting. Do know that the most common oral form is metformin, and this is the gold standard for type 2 diabetes when they are initially diagnosed. Now, we also need to tell them that they need to be followed up. This needs to happen immediately after they're discharged from the hospital, usually within 2 to 7 days. They're going to get a follow-up hemoglobin A1C, and this is going to help guide the treatment modalities by evaluating the response to the medication regimen that they're currently on. It also helps us as practitioners to determine if we've got well-managed diabetes, if there's good adherence to the treatment regimen or not. Yeah, that hemoglobin A1C. All right, so diabetes, we are out of that particular diabetes topic and into another. This is not the sugar diabetes, though. This is diabetes insipidus. Diabetes insipidus, or DI, equals dry as the Sahara Desert. Diabetes insipidus means that we have a complete or relative lack of antidiuretic hormone, otherwise known as vasopressin. We actually saw that yesterday when we were looking at our compensatory mechanisms in heart failure. It could be caused, this DI, from a nephrogenic source, meaning that the renal tubules actually have become desensitized to the effects of ADH. Sometimes that's perpetuated by drugs such as lithium, phentoin, and others. Or it could be that the DI is central DI or neurogenic. It means that the ADH is not being produced by the posterior pituitary. Potentially they have either damage to the pituitary or some type of tumor. So again, usually it can occur to severe head trauma, which damage the pituitary, or brain or pituitary tumors. So central diabetes also may be because the posterior pituitary is unable for some reason to secrete vasopressin. The thing that you see with your patients who are developing DI when you're doing your assessments is that they're peeing. I mean, they are putting out volume, mega volume in urine, and that urine is crystal clear. They are unable to concentrate their urine. So of course, putting out all this urine, they're going to become dehydrated, right? So they are going to be thirsty. Thirsty, thirsty, thirsty. They're going to have severe polyuria, meaning that they put out 5 to 20 liters of urine in a 24-hour period. So then you're going to see, when you assess them, signs of that dehydration through decreased skin turgor and dry mucous membranes. Of course, in their vital signs, you're going to notice that that heart rate's gone up and that blood pressure's dropped. Yeah, they just can't access water, and they can't get enough fluid. So diagnostics with this patient is we're going to monitor those sodium levels, because you know, water and sodium, they go hand in hand. One tells you about the other. So with this particular patient, when you get those electrolytes back, you're going to see that your patient is hypernatremic. And you get that osmolality level back, you're going to see that their osmolality is greater than 295. It's probably around 310 because they are so dry. So they're going to have a high sodium level of greater than 145. They're going to have a high serum osmolality level because they're dry as a bone. They're going to have a decreased urine osmolality because they can't concentrate it, so it's going to be less than 500. And they're going to have a really low urine-specific gravity. Normal is 1.010 to 1.030. For this patient, you may see less than 1.005 because they don't concentrate their urine. So again, we're looking at our diagnostics, we're looking at our assessment, and we're waiting for interventions based off of the orders that we're going to get from our physicians after they see these diagnostic tests. Treating, we may implement a little subcutaneous vasopressin or IV if they're in the ICU, and then later convert that to intranasal DDA-BP, which is the same thing as vasopressin but in a spray. Volume replacement is going to be crucial. Of course, if you're putting out tons and tons of fluid, you have to make sure that you give that fluid back and that there is a balance. We're also going to monitor and correct those electrolyte abnormalities as we see them, and we're going to put them on the correct IV fluid, especially for those sodium issues, right? If they have hypernatremia, they're going to need to do what? Replace the water that they're losing, right? Replace the water. And how do we replace the water? We don't want to give them normal saline when it's really, really high. We want to give them D5W, D5W.2, for instance, because they'll metabolize the dextrose, and that will leave them with water and just a little bit of sodium. Every physician's a little different in how they approach that hypernatremic patient. It all depends on the symptomology, okay? In determining which one of the IV fluids they're going to put them on. So strict I&O, this patient definitely needs a Foley catheter, okay? Otherwise they're going to be sitting on a bedside commode because they're peeing constantly. Serial labs, again, we're going to be monitoring the electrolytes, so a basic metabolic panel, and then of course the urinalysis to watch for our specific gravity, for instance. So now let's look at the opposite side of the spectrum. We just looked at DI, and they're dry as a bone because they're peeing their brains out, okay? And we talked about giving them back the water that they're losing through D5W or D5.2, for instance. It all depends on what your physician is going to do there. But it's the IV solution here that's really going to be important in our interventions and implementation, and then monitoring them for a response to that. So now, DI is on one side of the spectrum. The other, we have SIADH, or Syndrome of Inappropriate Antidiuretic Hormone Release. So what does this mean? It means I have an excessive release of antidiuretic hormone, or ADH, vasopressin. This is going to lead to a decrease in the urine volume, and our urine is going to become very concentrated. And this can actually progress to water intoxication, cerebral edema, and death. So it's nothing to fool with, but it's interesting. It's very common in the hospitalized patient. So with this one, we're going to see that patient who is getting water toxic develop a dilutional hyponatremia, a dilutional hyponatremia. So their sodium level is going to drop. They're going to be literally, swimming in water. Now, again, diagnostics, we're going to look at their serum osmo levels, and it's going to drop to below 280. Because remember, normal is 280 to 295. So high and dry, low and wet, okay? So it's going to drop to less than 280. Again, that urine is going to be very concentrated, which means that their urine osmolality is going to be greater than 500. Their specific gravity is also going to be very high, okay? It is going to be 1.030, for instance, in this patient. Now, who do you think gets SIADH? What population of patients? Who's at risk for syndrome of inappropriate antidiuretic hormone release? Well, shoot, quite a few patients to be exact, because it can be associated with central nervous system disorders, tumors, trauma, head trauma, lung cancer, oat cell in particular, COPD, pneumonias. Drugs can perpetuate SIADH. Some antineoplastics, surgery, anesthetics can actually perpetuate SIADH. So it's not uncommon to see this in our patients. Early on, you might notice that your patient's complaining of nausea, is developing a little vomiting, complaining of a headache, fatigue, shortness of breath. Later, when it's worsening, they're going to have a change in mentation because of that sodium drop, a decrease in level of consciousness, leading to coma, even seizure activity. That's why it's important to watch for changes in our patient. Sometimes they're subtle, sometimes they're blatant. So now with this one, because they've got too much water on board, they're literally water toxic, the conservative approach, if they're not severe symptomology, is going to be free water restriction. To pull off some of that fluid, they may be, you may get orders for loop diuretics, such as Lasix, or even a little Bumex. If they're a little more symptomatic, sometimes they're in the ICU, they may actually use a tetracycline antibiotic called dimeclocycline to help increase urinary water excretion. This antibiotic actually inhibits antidiuretic hormone at the renal tubule, but it's very, very expensive. And if those symptoms worsen more and we have severe symptomology, then you can expect to see that patient put on a hypertonic saline solution, because that's going to draw that fluid back into the vascular space, right? That's what we want. And they'll add a diuretic on top of that. But with that 3% saline solution, we have to be very careful in how fast it's run. It's going to go in slowly, usually 50, 75 mLs an hour. Some physicians may go a little faster. The pharmacy usually gives us a recommendation as to how quickly it should be infused. And with that, you have to remember that sodium levels, we don't want to raise them too fast or drop them too fast, because that's going to cause more problems. If we raise the sodium more than 10 milliequivalents per day, okay, it can actually lead to central pontine demyelination and a condition called locked-in syndrome. This is very, very, very uncommon. I've actually seen it once in my almost 30 years of practice, but it could happen. And literally the patient cannot talk, can't eat, can't breathe, they're locked in their body, they're on a ventilator, they're fed through tubes. So considerations as far as those fluid balance disorders go, because that's what we're looking at when it comes to these sodium problems. We want to monitor their heart rate and their blood pressure, neuro checks, because as we just saw, whether it's too high or too low as far as that serum sodium goes, it can affect mental status. It could lead to coma, it can lead to seizure activity, it can lead to death. So accurate INOs, daily weights, oral care are all considerations as far as those fluid balance issues go, and monitoring the serum sodium and other electrolytes, as well as making sure that they are on the appropriate IV solutions given their condition. All right, let's do a little bit of endocrine Q&A and then we'll wrap this session up. So which of the following is a feature of hyperosmolar hyperglycemic syndrome? And remember too, in some of your answers, it's pretty straightforward. Not always. Usually there are 2 great answers and 2 that you could pretty much throw out. So which of these following is a feature of HHS? Hyperphosphatemia? No. the phosphorus is going to fall. Excessive urine output. Absolutely. Polyuria. They put out liters and liters and liters of fluid. Okay, so something simple, straightforward, excessive urine output. Decreased anion gap. The anion gap is not affected as much in HHS because it is not an acidotic state. Hypokalemia. Their potassium all depends upon how severe a dehydrated state they're in. But what we always see is excessive urine output. HG is admitted to the medical unit with a diagnosis of SIADH. What lab value is most likely to be seen with a diagnosis of SIADH? And we just went through this one. So we know it's going to be a sodium level. So with SIADH, which one is it? SIADH, they have a dilutional hyponatremia. So the answer is going to be C. We see hypernatremia in our patients with DI. We see elevated serum osmolality in our patients with DI. We see hyperkalemia probably in our patients with DKA initially. Then it's going to fall. The nurse is taking care of Ms. T, who is admitted for diabetic ketoacidosis. She's a newly diagnosed diabetic, so discharge teaching with Ms. T is going to address her long-acting insulin, Lantus, and her regular insulin. Now, the patient's going to check her blood sugar before meals and at bedtime. This is given to her in her instructions. The regular insulin, or short-acting, is going to be for prandial coverage. The patient asks, what does this mean? The nurse's best response is which of the following? So again, look at the question and what is it asking for? Well, the patient wants to know what prandial coverage with short-acting insulin means. What is it for? Why am I doing prandial coverage? What is that? Okay? That's what we're looking for. We're looking for the answer to that question. So the answer to that question is going to be prandial coverage is done before meals to manage sugar elevations during meals, right? That's what we do with prandial coverage. It's not done after meals. It's not done at bedtime. It's not done before breakfast, okay? It's done before meals to manage the sugar elevation during meals. Okay, IT's an 18-year-old female. She's got nausea and vomiting. She's had it for 24 hours. She's lethargic and has fast, deep respirations. Lab values are as, lab values are potassium 6.1, bicarb is 14, glucose is 450. Based on these findings from your diagnostics, you should anticipate the following treatment. So what's going on with this patient? Looking at those lab values. Well, for bicarbs 14, glucose 450, I'm betting this is diabetic ketoacidosis. So you should anticipate orders, okay, that we're going to intervene with to be normal saline infusion and then IV insulin, okay? Now, MR is diagnosed with hyperthyroidism, therefore, the nurse should expect signs and symptoms similar to which of the following? Myxedema coma? No, because we see that myxedema coma we see with hypothyroidism. Addison's disease? No, that's seen with adrenal insufficiency. Beta blocker overdose. No, that would kind of slow things down, wouldn't it? Yeah. Sympathetic nervous system stimulation. That's the symptoms that I'm going to be looking for. Yeah, I'm going to expect signs and symptoms of sympathetic nervous system stimulation because hyperthyroidism is a hypermetabolic state. And that means that I could have an increased heart rate and increased blood pressure. Does that make sense? Hope so. Okay. That's it for this module.